Hello friends, I am Dr. Cüneyt Sevinç. I am a varicocele surgeon especially. I am operating varicoceles for more than 20 years now. And we are operating with our special technique, Istanbul Varicocelectomy. This is a microscopic open varicocele surgery with delivery of the testicles and removing of the varicoceles as it is implied in the name varicocelectomy. We are removing the vein, taking out the veins. So today I want to talk to you about varicocele embolization. Why I want to make this talk? Because I have many patients coming from all over the Europe and the rest of the world who had varicocele embolization, but they have recurrence. So when you research the literature, the varicocele embolization has a 70% success rate. As I had many patients and operated them and see what's going on in these patients, now I had a quite experience why the varicocele embolization is failing at some of the cases. So I want to tell you about the theory of the varicocele disease. This is a testicle. The testicle has three types of veins. One is internal veins, one is external veins, and the other one is the gubernacular veins. So as is here, we can see the internal veins are located inside the spermatic cord, and the external veins are located outside of the spermatic cord, and the gubernacular veins are at the tip of the testis. And when we look at this, the drainage of the testicle with the internal veins go to the left testicular vein. But the external vein is drained to another part. This is iliac vein. The vein comes from the legs. And this drainage is a different part. And the gubernacular veins are also joined with the external vein, and they are drained not into the left testicular vein, to another testicular vein. So this difference is important. Here we can see how embolization is done. They access from the femoral vein, they go through the iliac vein to the main venous system in the body, vena cava, and then they turn to the left renal vein, and they turn to the left spermatic vein or the testicular vein, and they put a coil here. They put this coil, this little, small, non-invasive, let's call it non-invasive substance inside the left testicular vein. Okay, this is how they go inside, and they come into the spermatic vein, and they put the coil. Oh, but here we see many coils. Why? Because the varicocele is a very difficult disease. Sometimes the veins are too large, and one coil may not occlude all of the venous structure. So remember, these coils will stay there forever. So they are not dissolving by the body. They will stay there forever. So they put here many veins, which is sometimes not good. You will have the coil inside forever. And here, as you see, to be really successful, sometimes they have to put a real big amount of coils inside. In such cases, you can see these permanent devices will stay there forever. It's difficult sometimes to reach the right side, but our colleagues have good ability. They can go to right side and left side, but don't forget these coils will remain here as long as the patient lives. And why it's failing? In my procedures, when the patients come to me, I find out that sometimes half of the system is very successfully done with the embolization, but the remaining half in the internal veins. I am not talking about the external or gubernacular veins, which are impossible to reach with the embolization process. But sometimes half of it is good, half of it is untreated. So we noticed that in some patients, the spermatic veins, internal spermatic veins, have abnormalities. They are, in this case, our radiology colleague find out nicely that this guy has two veins, and they occluded all of them, which is good for the internal veins to be occluded completely. But here, they occluded one of the veins, but there are many abnormal veins in this patient, and it's very difficult to occlude all of these. Yes. And here also, they go from the main vein, they put some devices here, but the rest of the veins, it's very difficult to reach them. And here also, we can see the coiled vein here, but sometimes when you occlude this part, still there are some branches going to other parts of the vein, going to other veins. So even you occlude the vein from here, the blood flow from the testicle will find another route easily in such a case. Okay, so when we come back, the embolization can reach only to this left testicular vein and its branches, it can find the branches, but the blood flow may continue from the other veins. So that is why there are many patients who have failed embolization. Is it a problem? Okay, as an initial therapy, you can choose one of these, because conventional microscopic varicocele surgery or embolization surgery or the old varicocele surgeries, or laparoscopic surgery, all of them has a 70% success rate. So you can choose one of them. If you had a failure, you can choose the other, but you should not forget about the external veins and the gubernacular veins. In our technique, we want to improve the technique and we want the success rate as high as possible. So we, at the first operation, try to finish all of these. Although it's very rare, there are some serious complications in varicocele embolization too. As I say, the device is permanent, it will stay forever, and sometimes with the blood flow, which is always pushing the coil can migrate to other parts. Here, there is a migration of varicocele coil to the right heart. So, is it very common? No, it's not common. It's rare, but it's possible. The coil can migrate. In this case, it's migrated to the right heart, which is, of course, a difficult situation. And another case, the migration continued from first the left spermatic vein to left renal vein, vena cava, to right heart, and to right pulmonary arteries. So this migration went to the pulmonary arteries, which is a rare condition, but nobody wants to have such a risk as an initial option. So I recommend strictly, as all the literature says, microscopic varicocele surgery is the gold standard still. So you have to do the first treatment with the microscopic surgery, and you have to ask for the external veins and the gubernacular veins to be treated. And if it fails, we have a 2 or 3% failure rate. It's very, very rare. We try to improve it, but still we have a recurrence rate. In our operation, gubernacular veins and external veins are easily treated, but when there is too much malformations or abnormalities, difficulties in internal veins, they are difficult to treat. So if I have a recurrence, best thing is embolization still, which is easy to reach all the internal veins and treat them as a best procedure. I can recommend embolization in recurrence of microscopic varicocele surgery, but as an initial therapy, it has too much failure rates and it has some side effects that must be known for everyone. Thank you.